I'm Dr. Jason Hawks. I'm a medical dermatologist in Northern California. On behalf of the International Psoriasis Council, I'm going to be presenting this Take 10, which is going to discuss beyond plaque psoriasis, looking at some of the other disease variants. These are my disclosures. The objective for this Take 10 is to review the non-plaque psoriasis variants and their relationship to traditional plaque psoriasis, as well as some of the ongoing efforts to provide more personalized treatments for the non-plaque clinical subtypes. As you know, psoriasis is a systemic disease. It's a chronic condition that's heterogeneous. This is a good collage of pictures, which shows a number of ways in which psoriasis can present, from both skin involvement to nail disease, also involving the joints and psoriatic arthritis. And one of the acute forms of psoriasis we'll talk about on the far right, guttate psoriasis. As you know, IL-23 and IL-17 signaling is really central to the pathogenesis of plaque psoriasis. Highlighted here, you can see in a publication from 2018 that we did in the Journal of Immunology that really highlights the role of the T lymphocytes and the dendritic cells, which are the primary source of both TNF and the IL-17s, as well as IL-23, and then IL-17C coming from the keratinocytes. These interact with each other to perpetuate this chronic mature plaque, which is what characterizes the clinical disease of plaque psoriasis as we know it. And most of this data has been obtained from biopsies of the skin of traditional plaque psoriasis. But what about the non-plaque variants of psoriatic disease? Is IL-17 and 23 signaling also central to their immunopathogenesis? We're going to explore that a little bit today. So psoriatic disease is really more than just plaque psoriasis. As you can see here on the far left, plaque psoriasis represents about 85% of psoriatic disease. We have these other variants, which we're going to go into, from guttate psoriasis to inverse refluxural psoriasis, which includes genital psoriasis, pustular psoriasis, and erythrodermic psoriasis, highlighted here in red as these are more emergent and more widespread. If we look at guttate psoriasis first, it's about 10% of the other non-plaque variants. And this picture here is a patient I saw in clinic. You can see these widespread small lesions. They're smaller compared to traditional plaques. They have light, thin white scale. Although these patients can have larger plaques, it's traditionally been associated very strongly with a susceptibility loci, HLA-C0602, formerly CW6. Very high rates, nearly 100%, as opposed to about half of patients with plaque psoriasis. While this is classically known to present in kids that are, young adults or even kids that have had strep infections, that's not always the case. There's really no strong evidence for tonsillectomy or antibiotics as a treatment for the psoriasis, while we do treat the infection. And this eruptive form can really exist. It can present in patients who've had pre-existing plaque psoriasis, or it can be de novo, and sometimes that can be a clue these patients are at higher risk for plaque psoriasis. Most cases of guttate psoriasis are self-limiting, but they can turn into chronic disease. About a third of patients go on to develop chronic plaque psoriasis after a guttate flare. Anecdotally, it's been very interesting because we've seen traditional anti-psoriasis plaque treatments work, such as the biologics are also immunosuppressants, but there really has been no systemic molecular characterization of guttate psoriasis. However, a number of reports, including the first publication here, a case series of patients that failed a number of systemic treatments for their guttate psoriasis and responded very well to even a single injection of ustekinumab, which put many of these patients in remission. We have similar publications from Mount Sinai looking at the IL-17 inhibitors as very effective treatments of guttate psoriasis, and also from Wake Forest treatment with an IL-23 inhibitor, guselkumab, also putting these patients in remission. So this really suggests a shared immunopathogenesis between guttate psoriasis and plaque psoriasis, even though they have very different clinical features. But however, there really are no dedicated clinical trials for this variant, and all other clinical trials really include this subtype. If we look at inverse refluxural psoriasis, about 5% of other cases, picture shown here, showing involvement underneath the inframammary folds. This is the type of psoriasis that really involves the skin folds. So axilla, groin, genitals, as I mentioned. And because of this moist environment, they typically have a very little or absent scale. It's very commonly misdiagnosed for that reason, such as tinea cruris or intertrigo, which can look very similar, occur in similar areas of the body. It's often underdiagnosed as well because many patients are not examined carefully, or clinicians don't ask patients to derobe or take off clothes, and this can hide these areas which may be involved in your traditional patients. And like the other variants, this can occur de novo with patients who have never had a history of psoriasis, but it can also occur in patients who've had traditional plaque psoriasis. They can go on to develop some aspects of inverse disease, and it can occur in as many as 80% of patients. So this is actually quite common finding if you look for this. Genital psoriasis is a very unique special site. It impacts the quality of life and daily activities to a very high degree, even more so than plaque psoriasis. Is very bothersome to our patients. Looking at how we categorize patients, the International Psoriasis Council several years back made a consensus statement really highlighting how traditional terms such as mild, moderate, and severe disease really didn't capture the impact that inverse disease, for example, or involvement of special sites like the scalp, for example, or the genitals can really impact patients. And so you can see that these traditional terms are rejected in favor of the traditional using body surface area, but also disease of special site involvement, such as genital and scalp, failure of topical therapy. These would be reasons to push patients into more systemic therapies and not to be constrained by the traditional buckets of mild, moderate, and severe. For that reason, industry partners have recognized the need to look specifically at whether their treatments work for this subtype of psoriasis. We have a number of trials showing good efficacy. Ixekizumab, for example, had dedicated genital study, apremilast in their discrete study. And we also have an ongoing study with an IL-23 inhibitor, guselkumab, in the Gulliver study, looking specifically at their effectiveness for this specific subtype. Topical therapies, roflumilast, for example, specifically looked at intertriginous IgA success. Crisaborole, very similar. And this is important information to communicate to our patients as they ask how well or how effective are these therapies for my type of psoriasis. We move towards the pustular and erythrodermic forms of psoriasis. These are more urgent, less common, pretty rare, and they can be very severe in our patients. If we look at erythrodermic psoriasis first, it's really characterized by widespread confluent erythema, typically about 90% of the body surface area, as well as systemic symptoms, often with pustules and skin desquamation, as you can see here. And this can occur also with traditional psoriatic plaque. So if you see those, they can kind of be a mixed feature in this erythrodermic type. This is, as I mentioned, it's rare, potentially life-threatening. Mortality can be as high as 64% due to complications, infections, for example, very common complication with this type. But also organ failure can occur. Most common trigger in these patients is usually oral corticosteroids or a sudden abrupt withdrawal of anti-psoriasis medications. Conversely to that, there are case reports and studies indicating that traditional treatments can also trigger erythroderma. So retinoids and methotrexate, for example, have been suggested as potential drug-induced causes of erythroderma. We're not going to get into the differential diagnosis of erythroderma. It's very broad, but it is very important that we consider that wide differential and do a careful workup in our patients who present to ensure that they truly have erythrodermic psoriasis as opposed to another cause of erythroderma. There was a publication in the JID in 2016 looking at the molecular profile of these, some of these variants, like inverse erythrodermic compared to chronic plaque psoriasis. Very interestingly, there's very high overlap in the differentially expressed genes. So about 95% of these genes were expressed across the inverse erythrodermic subtypes along with plaque psoriasis. And not surprisingly, IL-17A signaling was really the major shared pathway in all of these variants. And there's numerous reports which are good proof of concept here. We're showing that the targeted biologic therapies have a high efficacy in these non-plaque variants. If we look at pustular psoriasis, it's really more of an inflammatory condition, really characterized again by pustules, as the name implies, or neutrophils penetrating into the skin and epidermis, forming these pustules or this lakes of pus. You can see some of the pustules here on the right side in this patient, one of my patient's arms here on the forearms. Looking at the nomenclature, this has been confusing. There have been efforts to try to characterize better or categorize these types of pustular forms of psoriasis. These are the three most common type, which I'll show you. Generalized PPP we'll talk about a little bit more, as it's more of a widespread disease as suggested by its name. Also rare, life-threatening subtype. It can be isolated, one-time event, or it can be chronic relapsing disease. And in the US, it's estimated to be about 1 in 10,000 patients. So this is not very common, but they definitely have more severe skin involvement, and they can have systemic symptoms. Leukocytosis, fever, malaise, elevated ESR or CRP are pretty common in these patients as well. There's a very high disease burden, and it really impacts their quality of life. Nomenclature, as I mentioned, been confusing. The Erasmus statement here to try to help clarify some of the definitions for these types. You can see here with generalized psoriasis, it's really more widespread, and it's pustules outside of the traditional psoriatic plaques. And this can be with or without a history of plaque psoriasis, as they all can. Palmar plantar psoriasis really restricted to the palms and soles, which helps differentiate it from pustular psoriasis, the more generalized form. And then acrodermatitis continuum of Halipo is really affecting around the fingers and the nail apparatus, and again, with or without psoriasis. That helps kind of categorize these pustular forms. And one aspect that's really important for the pustular forms is that IL-36 cytokine is really central to the development of generalized pustular psoriasis. This figure here shows the IL-36 cytokines, the alpha, beta, and gamma, which is part of the IL-1 family, the superfamily. And we have also some built-in antagonists, so IL-36 receptor antagonists, which helps kind of stop signaling. And when we look at patients with GPP IL-36RN mutations, what really is happening is you're losing the brake. So these patients have this unopposed IL-36 signaling, and this creates this feedback mechanism where the IL-36 signaling can activate the immune response. The activated immune response then further activates production of IL-36, again, in the keratinocytes, a hyperproliferative state, and really driving this condition. IL-36 mutations are very common in patients with GPP, but actually they're more common in patients who have no prior history of plaque psoriasis. So if we look at patients with pustular forms of psoriasis who also have GPP, they have very low percentages of IL-36RN mutations. And then there's been some very exciting recent developments with making selective therapies against the IL-36 receptor for the treatment of GPP, so zolumab, which is an anti-IL-36 receptor and IgG1 antibody, which is given IV. And that is approved here in the US and some non-US sites as well. Imsidolimab is also an anti-IL-36, but subcutaneous. It's a different antibody. It's IgG4. So these are exciting treatments that really target this IL-36 component. So I hope this gave you a good overview. I want to just highlight the fact that psoriatic disease is a heterogeneous disease. It does have systemic inflammation, and we really need to understand and recognize all of the variants as we treat our patients. There is a clinical need for these specific studies because there is a bias towards plaque psoriasis as opposed to non-plaque variants. We really want to have this, we want to develop and understand these precise immune relationships and genetic relationships of these plaque versus non-plaque variants as we start to tease that out. And there's really a need for trials and more research to really develop and understand these therapies that'll work best for this condition. I want to thank you for your time.